Hi, everybody. Welcome to the Get Healthy Tampa Bay podcast. I'm your host, Dr. Kerry Reller, and today we have a very special guest, Dr. Gina Kirkpatrick. Dr. Gina, welcome to the podcast. Could you please tell us who you are and what you do?
Hi, thank you for having me. I'm a urologist in the Tampa Bay area. I practice at Advent Health in Wesley Chapel. I have a fellowship in addition to being a board certified urologist, as I am trained in female pelvic medicine and reconstructive surgery. And that just basically means I do a bunch of things to help women with prolapse and pelvic floor issues, in addition to general urology. And obviously within the context of general urology falls urinary incontinence. So I'm originally from Atlanta, Georgia, trained in the Philadelphia area as well as the New Jersey area. And I've been in Tampa area since 2017.
Very nice. Very nice. I'm happy to have you today. What made you go into urology?
So that's interesting. When I initially thought I wanted to do general surgery because I love the surgical aspect of training, and kind of happenstanced onto a urology rotation. It was like a last minute change. And surprisingly, I loved it and they loved me. And then there were two guys and they were elderly and they thought, oh my goodness, our elderly patients like you, we may be onto something. So then they introduced me to a female urologist in Atlanta, Dr. Janelle Foote, who was kind of one of the first female urologists in the area. And I absolutely loved her. And so that solidified it for me at that point.
Awesome. I feel like there are more and more female urologists that are going into the specialty now, which is awesome because it was much
absolutely
needed. Yeah. So
absolutely
glad you did that. All right. So you mentioned a urinary incontinence, and I think that's going to be our topic today. So can you tell us why that topic is important?
Yes. So urinary incontinence is one of those things I probably see most frequently, as well as when we think about the number of patients that address the issue of their primary care physician before they even get to a few talks on this. There was some recent data that came out on 2015 to 2018. It really represents about 60% of women in the United States in what they call community dwelling environment, meaning they're not in a nursing home or a hospital. 60% of all forms of urinary incontinence, which is a huge number. And this was a large clinical trial that was studied from 2015 to 2018. It was published in 2022. Then also, when you look at women that have not had children, that overall prevalence was 30%. So some of the risk factors that we've noticed in the general population, age over 70 is a risk factor. BMI, the higher the BMI, the more likely you are to have those symptoms. And vaginal birth was also a strong indicator or factor for urinary incontinence in the older population. And then when you looked at women that had not had children, when we looked at the type of incontinence, stress incontinence was the most prevalent. And we'll talk about the different types of incontinence a little bit later. And then urgency and frequency was also very prevalent. And for that group, the risk factors were increased age, increased BMI, and interestingly as well, smoking was a risk factor.
Okay.
Yeah.
So urinary incontinence obviously can be a big problem for quality of life people. I think you probably see people on all the spectrums, but did you want to comment on that?
Yeah, absolutely. So, when we talk about incontinence, or can you hear me?
Yes.
Am I frozen? Okay. All right. You know what? Let me do something. Let me see if I can turn off. I think those are maybe emails trying to come in. So let me see if I can turn all of that off and it stops it. Okay. All right. So there are four primary types of incontinence. So The more common that we hear about is you see all of these absorbent pad commercials and things is the gotta go, gotta go, gotta go. People get the urge to go and they can't hold it. And so they get to having to wear pads and adult diapers. They do what we call bathroom mapping, can't go out to the movies, can't go out to the mall without knowing where all of the bathrooms are. And that is a large percent of the patients that present to the door of their primary care physician. They usually try a couple of medications on them and then send them to a urologist. And so that's kind of is the constellation of urge, urinary incontinence, frequency, and that can be with or without incontinence. And we kind of call that whole segment of overactive bladder. Okay. So we use those interchangeably oftentimes. When we use overactive bladder terminology, we basically kind of define it as wet or dry, so you have the symptoms, but do you leak or not leak? But it's the same constellation. So we pretty much work it up and treat it the same. The next is stress incontinence, which is the subject of your podcast today. Why do I leak when I laugh?
Yeah.
Exercise, jump, run. That is, there are two types of stress incontinence, well, two reasons for stress incontinence that we've most often identified. The first is typically an anatomical hypermobility of the urethra. The pelvic floor sometimes will get looser, or those periurethral ligaments get looser. And so when you increase your intra-abdominal pressure, either through coughing, laughing, sneezing, exercising, the urethra kind of pivots down, and then urine in the bladder can leak out. And then there are those people that have what we call intrinsic sphincter deficiency. Their stays all the time. It
Can you repeat that?
leaks very freely, and so they leak. So the other is intrinsic sphincter deficiency.
Okay.
It's a form of stress incontinence, but that person has a urethra that kind of stays open. We call it a stovepipe urethra. And so they have a tendency to leak at really low pressures, like sometimes getting from sitting to standing or getting out of bed. And they leak very easily. And so they're both considered types of stress incontinence. Okay. Then there's functional incontinence, which is more so if you've had a back injury or hip injury or knee injury and you cannot get to the bathroom in time. We call that functional incontinence. And then finally, there's overflow incontinence. And that typically is when the bladder cannot hold the capacity of urine. And that can, interestingly enough, I have a patient now who has what's called diabetes insipidus, and she makes sometimes 6 liters of urine in a day. Well, a normal person can't hold that amount of urine in their bladder all day without leaking. It would be very rare. So she has overflow incontinence, but you can also have overflow incontinence because your bladder, there's some type of obstruction preventing your bladder from emptying, and it gets so full and has nowhere to go, and so it leaks out of the urethra. Okay.
I'm getting some CME here because honestly, I've gotten confused about all the different kinds of incontinence as well. So this is great review for myself.
Good.
So I guess, how do you differentiate all the different types? Like, what kind of testing do you do when you see a patient?
Absolutely. So, you remember in med school when they would say, if you just listen to the patient, you've got most of your differentials right there. So a lot of this is really listening and asking very specific questions like, are you leaking when you work out? Do you have frequency? And when you're trying to get there, do you leak? One of the things we see oftentimes is that people will be fine, and then as they're pulling into their garage and they're starting to put the key in the door, and then the waterworks start, right? So you ask those specific questions initially. You need to do, oftentimes I do what's called a bladder scan in the office, have them urinate, and then ultrasound their bladder to determine what their residual is. Okay, so if
So how
they
much is
have
left in
a
the
really
bladder?
high residual, say for a man, if
Mhm.
it's over 300, exactly. And so based on that number, that can give me an idea if in fact if it's more likely to be overflow incontinence. Functional incontinence, you can determine just by asking specific questions. So I think that's the first thing,
Mhm.
is really doing a full, thorough, history of present illness, a physical exam, and then sort of determining. Now, one of the things that I didn't mention of you can have a mixed incontinence picture as well. So
Mhm.
you can have stress leakage, jumping, running, as well as overactive bladder symptoms, frequency, urgency, leaking with that. Those patients are a little bit more complex to treat. And oftentimes they end up getting what's called a urodynamic studies test.
Mhm.
If they can't tell you what's more prominent or what's more problematic for them, then oftentimes they will get a urodynamic studies test. And sometimes they can't tell you, like they're like, yeah, I have the urge all the time and I leak and I don't feel it, So then,
Mhm.
you can't, I don't like to necessarily throw medication to people or some other treatment. So oftentimes I will do a urodynamics on that particular population. Urodynamics test is, I almost call it like an EKG of the bladder. A little small catheter goes in the urethra, into the bladder. One goes up into the tip of the rectum, and they have monitors on the end of them. And then you slowly fill the bladder up with fluid, and you can see what the bladder is doing as it's filling. And they will tell you the sensation. You ask them, tell me when you have your first sensation, when you have your first urge. And then when they get to a certain level, I'll have them cough at, like a light cough and a heavy cough. And that measures to me at what pressure their urethra leaks or if they don't leak, okay?
Mhm.
And that's useful when you're treating the stress incontinence. And then you have them urinate. And with that, I can see what their bladder is doing. Is their bladder squeezing really hard to get urine out with a low flow, or is it squeezing, efficiently and sufficiently to adequately empty? And then based on that, you kind of decide, okay, really your problem is stress leakage, and then you deal with kind of how you're going to treat the stress incontinence, or really your issue is overactive bladder. And so we need to do some things to kind of stabilize your bladder muscle so it's not contracting and leaking all the time.
So, well, you mentioned what you can do to stabilize the bladder muscles. So what would
Mhm.
that,
Mhm.
what's something like that?
So, we start, believe it or not, the first line therapy to overactive bladder, because that would be that situation,
Mhm.
is behavioral modification and pelvic floor therapy. I mean, we love that
Mhm.
because, especially in my younger population, when you start talking about putting people on medications and things in the younger population, this is something potentially they're going to have to do the rest of their life because it's just not going to rectify itself being on the meds. So if you
Mhm.
work with them with behavioral modification, the things that make your bladder irritable, work with them on diet, what fluids are better. For example, we know that caffeine is a bladder irritant.
Mhm.
We know spicy foods are bladder irritants to certain people, and really work with them on their diet. One
What do
of
you mean
my
by the
partners used to
diet?
swear that Mountain Dew.
I just asked, what
So
do you mean by the diet? Yeah.
some spicy foods are to
Oh, okay.
people. And so just really being cognizant of that and just working with them. And pelvic floor therapy, I love because the physical therapist teaches them before it has to go, right? So
Mhm.
they give them strategies and they also make them do a diary about what they eat, what they drink, what time they eat, what time they drink. If they're getting up at night, work with them about when to slow the fluid consumption down. So I really love that part of it. And so
Mhm.
I try to get as many people that have overactive bladder into those behavior modification pathways and pelvic floor therapy first. But obviously people come to you, it's expensive, because it's physical therapy. And then you have the
Mhm.
people that say, I don't want that. I want to fix like tomorrow. I'm going on vacation tomorrow. Like, I need to know. I need to have something. So if they refuse that, you still have to encourage the behavior modification, but then you also you have to offer them some choice. So there are medications then, right? So now we're on to our second line therapy, of therapy for this treatment. And so that basically would be medications. We have two different classes. It just kind of depends on if they have a history of constipation or memory issues. You want to stay away from the oldest class of medications, which we call anticholinergics or antimuscarinics, and then direct them towards the beta agonists, which are the newer class of the medications. They work on different cells in the body, but ultimately the goal is to allow the bladder to hold more urine and leak less.
Okay.
And to diminish the amount of frequency if that's their primary issue. So those are the second line therapies for overactive bladder.
Okay. And then are there any surgical or third line, or how does that work?
Yeah, so third line therapy, right now they're primarily two. There's injection of Botox in the bladder. And I have people ask me all the time, I didn't know my bladder had wrinkles. And so what Botox does, is it basically deadens some of the cells in the bladder, the anticholinergic effects of some of the cells in the bladder so that it doesn't squeeze as frequently, and it slows down the urination and incontinence. Typically, you have to have it every 6 months on average. Some people are about it every 5 months. You can do it in the office. You can do it in the operating room. There's, other than the risk of Botox in and of itself, it's minimal, there are minimal risks with it. And, I have some patients that prefer it over the medication because once they have it, they don't have to think about it anymore for about 5 or 6 months. There is a small risk. You look at the studies, anywhere between 5 to 7% of urinary retention, and that it works too well, and then you can't urinate. And in those people, they either require a catheter for drainage for a few weeks till it wears off. But most of the time, it's probably happened to me about 5 times I can recall in 10 years. And most of those people I just taught to cath themselves until it kind of starts to wear off. Okay, that's the first. And then the second is something called a sacral nerve stimulator. There are 2 products on the market. I've used both, but it basically is a little device that is implanted. It kind of like the top of what we call our butt, the gluteal area in the subcutaneous tissue, and it has a lead that goes alongside the nerve that controls the bladder. And so it actually works for fecal incontinence as well, because that particular nerve handles fecal incontinence as well as urinary incontinence. And so it, has a constant stimulation to it, and over time it modulates or dampens that response. And so it kind of slows down the frequency and the urinary incontinence and the fecal incontinence as well.
So after patients have undergone one of these treatments, how do they report back their quality of life improving?
Yeah, so for this sacral nerve stimulator device, we do a trial. So they either have a temporary device and lead placed in the office or in the OR. And, if it's placed in the office, they know within a week. If it's in the OR, it's a more permanent implant. It's actually the actual permanent implant. We give them up to 2 weeks. And if it works, if there is 50% or greater improvement in their symptoms, and they have to keep avoiding diarrhea, and they also have to keep a pad, how many pads per day. And if there's 50% or more improvement, then we implant the permanent device. As far as Botox, they follow up in a week with a post-void residual to make sure that they are emptying their bladder sufficiently. And then at that point, they usually don't start to get the benefits of it for about a week out. 5 to 7 days is usually when they start feeling it. So I see them about midpoint, probably about 8 weeks after the injection, to see how they're doing. And most people, both of these have really good patient response rates, greater than 80% in most cases.
Wow, okay.
You look at most of the studies. And so, most people tolerate the procedures well and they do well with them. But again, they're happy to get 50% improvement because to get here, they've tried everything else that's failed. So, they're happy to get some improvement. But that's also important, is that you have to manage expectations. This problem is not going to fix itself. You can't get InterStim and then go drink, 10 Coca-Colas or, drink, sip on, Dunkin' Donuts coffee all day and expect that you're not going to potentially leak. It's a tool, but you still have to practice your own, behavioral modification things that we've discussed with you to get you where you need to be. So that's one of the major things. It's not a 100% quick fix. I just turn a switch and it's perfect. You've got to work with it as well.
Absolutely.
Okay.
You mentioned like the percentage of people, what was the percent? Women, I think, of who actually have urinary incontinence. The one was like undiagnosed.
Greater than 60% of community dwelling women. I was surprised at that study. It was like 61.98. And I can give you the article references that you can just post up on your website if they want to read the article. But yeah, it was greater than 60%. Now that was all women, so it didn't segment out if they had children or had not had children, but that was just the general population, which was crazy. And I think the age group was 18 to 75 or something like that.
So how many of those people do you think actually present to their doctor for help prior to even going to you?
Yeah, that's a good question. I believe that there are a large amount of people that are not treated for this condition because women have, even when they come in to see me about something else, say they're coming in because they have a renal mass and they've been referred for that. And part of my assessment for whatever they're coming for is to do a full kind of urologic assessment. Are you having incontinence? Blah, blah, blah. That's on the questionnaire. And most of them would say, yeah, I wear adult diaper. It's okay. And so they've just been, conditioned because of the advertising on television. That has been normalized. And that is one of my pet peeves because you don't have to live that way. Obviously there are people that have more complex issues like neurogenic bladder with some of the neurologic conditions that are harder to treat. And, but they too, there are treatments for them. There's a Botox strength just for people that have neurogenic bladder, which I think we probably should at least address because I'm sure you probably have some of that in your audience. People that have Parkinson's, multiple sclerosis, some of the other neurologic conditions, the bladder is often affected. And when Botox was even brought on the market for general use after a number of clinical trials, it was trialed in the neurologic population, spinal cord injury, MS. And so because it was to reduce the bladder pressures and to basically deaden the bladder in that population because their bladders were being drained anyway with either a catheter or catheterizing themselves. But what was happening is that because as a neurogenic bladder develops over time, it starts to lose its innervation. And so it has this high pressure to it. And a lot of times that pressure can be transmitted up into the kidneys and damage the kidneys. And so they, trialed Botox in that population just to kind of make the bladder dead. And so that's how it initially started. So there is, I do have several people that have spinal cord injuries and some of the other things, MS and Parkinson's, and I Botox them as well, but it's with a much stronger strength for the same reasons.
Gotcha. So I feel like one big thing here would be just because it's common doesn't mean it's normal, right? And they should come seek help. When should they come see you, like a urologist?
Yeah, I think to be honest with you, because even when you go to your primary care physician and they throw you on a medication, say one of the anticholinergics, the problem is you haven't really been able to assess that patient to determine, how do you know it's really overactive bladder? What if it's overflow incontinence? Because there are no tangible ways to assess that. And so I I don't mind when they come to me and they haven't had any prior treatment, because it allows me to kind of do a full assessment on them.
Mhm.
And I will tell you, on several instances, there have been other things going on, and that was just a symptom of it, right? So, we know multiple sclerosis oftentimes presents earlier, and then these women come in their 30s and they have really bad frequency, and but they haven't been diagnosed with MS, right? And so
Mhm.
they, come in and you find out that this is ultimately kind of probably what their issue is. But, a lot of times primary care physicians may not know. So they're like, oh, well, that med didn't work. Let's put you on another medication. And I think some of the PCPs probably feel that they don't want to overwhelm us with a ton of consults for things
Mhm.
like urinary incontinence. But as urologists, this is what we do. The bladder is it's what we do. So I am never offended for a urinary incontinence consultant. I
Well,
would
that helps
just, if
me.
your patient person, so if a patient presents with, I'm having frequency and urgency, send them to a urologist. The problem is, it's so hard to get in because everyone moves to
Mhm.
Florida, right? So we're all booked out spots for new patient appointments. It's
That's
even
probably
okay to
true.
put them on it's even okay to put them on one of the lighter medications and then make that referral to a urologist so they can, because by the time if they see me and they're like, you know what, that med is awesome. And I'm like,
Mhm.
that's great. Let's, do a bladder scan, make sure you're emptying sufficiently, and then, kind of tweak things if necessary. But yeah, it's never the wrong time to do it.
Excellent. Excellent. So, any last advice for our listeners or?
Let me think. I think the most important thing is, you know, don't feel as if you have to suffer with this. I do
Mhm.
get some women, especially the young active women with stress incontinence. They run a lot, they're leaking while they're running, very active, and they change their lifestyle. I've had some patients that have stopped exercising before they come to me because they're so embarrassed by it. Um, one of the things that we didn't talk about treatment of stress incontinence. We talked about the overactive.
We gotta do that.
The stress incontinence is really important because, this is what we see, like I said, in the younger population. Overactive bladder, a lot of times I'll see in the older women, but the younger
Mhm.
population, you have one baby, you're likely to have stress incontinence. So there's great treatments. It used to be that we would do a big surgery called a sling, and we would, this was like 30 years ago before I was practicing, or 20, and they would take a piece of your fascia with your connective tissue and then wrap it around your urethra and then, secure it, and you have a catheter for a week or so. And that we call that autologous fascial sling. So it was your tissue. And then after that, they developed mesh slings, which did the same thing, but it was a foreign body and it was mesh, which, by the way, FDA came out and said it's still safe to use that mesh for that procedure for stress incontinence. But what scared people was that you had the whole litigation on the vaginal mesh that you heard about for prolapse repairs. And so people got scared. And so they stopped coming in for slings for stress incontinence. So they were suffering through it because they were scared away.
Mhm.
And then when Europe took their sling off the market, Europe took slings off the market completely. And so a European firm developed a product called Bulkamid, which basically is urethral bulking. You basically put these little pellets, and they're hydrogel pellets throughout the urethra to kind of close the outlet a little bit.
Mhm.
And it was designed for a specific population, but what they found is it worked well. So a company here now has that product. So that is one treatment for stress incontinence, and it's called Bulkamid. The other treatment is obviously pelvic floor therapy, because
Mhm.
sometimes if it's mild and it's just beginning, and say you just had a child, pelvic floor therapy is awesome for that because it helps to tighten up the pelvic floor, tighten up those periurethral ligaments, and then things kind of work better as far as preventing. You can know how to tighten which muscles when you're about to sneeze and exercise. Okay. And the sling is the last one. So, between bulking and sling and the old-fashioned autologous fascial sling, which we still do on occasion, depending on the patient, et cetera. And all these things are really dictated by the patient's history, the patient's needs, et cetera. But those are really good treatments. And so I would like for women to understand that there are minimally invasive treatments. Now you've got Bulkamid. If you're the right candidate, you don't have to have a foreign body or mesh, that are really, really good. There are not a ton of urologists in the Tampa area that do Bulkamid. So, if they call a urologist's office that they're interested in seeing, I have tons of patients that drive from St. Pete and Clearwater to see me. They're more than welcome to call my office. But, if they're interested in that, just tell them to call the urologist and see if they do Bulkamid or what their treatments for stress incontinence are. But I find that populations oftentimes overlooked because they are embarrassed. They don't think that there's anything that can be done. They don't have time because they have kids, et cetera, et cetera. And so, but yeah, I would definitely like people to come in and see someone about that.
Excellent. Did we miss any other ones? Because I don't.
I think we talked about treatment of both types, and the prevalence of it. I think that's pretty much it.
All right. So where can they find you then? Where can our listeners find you?
So I am at Advent Health Wesley Chapel Hospital. I'm on campus here. My office number is 813-929-5809. Now, I would like to mention, though, there are some new radio frequency ablation resurfacing devices on the market that have been used for vaginal rejuvenation in the past. There's one in particular, the Vive, that I also do sexual health and wellness at a practice in Orlando called MV Medical Orlando. That particular device has actually completed its pursuit clinical trial for stress incontinence. And so the data looks very good. So it looks like they may be one of the first and only companies that is approved for a minimally invasive treatment for stress incontinence. So we're really excited about the data coming out in January. If they're interested in that, so that's no injections. That's just literally a wand going in and out of the vagina around the urethra, kind of tightening that. The few ladies that I've done it on have had excellent results. So, we can use it for vaginal rejuvenation. We can use it for the stress incontinence, or both. And the ones that I've done just for the stress incontinence have done really, really well. So that too, if they're interested in that and they don't mind driving to Orlando, they can call that number as well. Let me give it to you. That number is 407-730-4244.
Okay. I will put that in the show notes too.
All right.
Yeah.
Okay, perfect.
Thank you.
All right.
Well, might have to do a whole
You're
other
welcome.
topic of all the new kind of devices that they're coming out. 'Cause I feel like I've heard of more. Yeah.
Absolutely. There's tons of stuff. And like I said, because I do the sexual health and wellness, that's a whole nother podcast we could do. Because there's a lot of great products and things that have entered the marketplace lately that I think probably our users could benefit from, because, most of my female population, as they get in their 40s, life happens, they have kids, sex is the last thing on their mind, but their husband are like, what are you talking about? And you literally physically don't have the desire to win sometimes. So that's a whole nother conversation for another day. But yeah, it's definitely
we'll have to bring you back.
Yeah, perfect. Okay.
All right. Anything else to add?
I think that's it.
Okay.
Yeah, I think that's it.
Well,
I hope
thank
you can see
everybody.
me with all this light out. Sorry.
I know. I'm good. My eyes are getting tired anyway, but we're good.